Good day and welcome to today's presentation. Please note this webinar is being recorded. All participants are in a listen-only mode. If you would like to ask a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn the call over to Lisa Sullivan. Please go ahead.
Good afternoon, everyone. My name is Lisa Sullivan, and I am looking forward to a wonderful event today. Welcome to the National CMS CDC Nursing Home COVID Training Curriculum, a series of national nursing home training sessions that are geared specifically to the pandemic. This training will allow nursing homes to receive recognition certificates for attending. In addition, in the future, we will have downloadable achievement badges made available for those who attend. Please remember to enter your CMS certification number, or CCN, when registering for future events so your nursing home gets credit. Thank you for taking the time to be with us here today, and a special thanks as well to our CDC colleagues for partnering with us on this important training series. A few reminders before we get started. The slides and resources can be found on the QIO program website, and the recording from today's event will also be posted there within a week, so be on the lookout. During the open discussion period, please keep in mind that we will get to as many questions and comments as time permits. But if there are any unanswered, we will address those post-event, and they will be included on the QIO program website once finalized. Next slide, please. It is my pleasure to introduce our speaker today, Dr. Namali Stone from the Centers for Disease Control and Prevention. Dr. Stone is the team lead for long-term care for the Prevention and Response Branch within CDC's Division of Healthcare Quality Promotion. She is a board-certified infectious disease physician with over 10 years of experience developing surveillance and quality improvement projects to track and prevent infections and antibiotic-resistant pathogens in post-acute and long-term care settings. During the COVID-19 pandemic, Dr. Stone and her colleagues have been leading the development of guidance, education, and implementation resources for COVID prevention and response activities in nursing homes and other long-term care facilities. Dr. Stone, the virtual floor is yours.
Thank you so much, Lisa, and thanks to all of you who have taken time out of your busy schedules to join us. It is a privilege to have a chance to talk with you. I look forward to a dialogue and a great conversation from your comments, questions, and perspective. So next slide. I know that this was billed as advice from the CDC, but I am going to shift that and say that I hope to share with you advice and great innovative work from wonderful providers around the country. I've been very privileged to have the chance to visit nursing homes since the beginning of the pandemic in early March and all the way to as recently as last weekend. And I am continually impressed and inspired by the tremendous teams and the work that you're all doing to support your residents and families. And so I just want to express my gratitude on behalf of my agency and all of our federal partners. Next slide. I suspect you're all familiar with this website, and I feel like I should say I'm sorry for how often it changes, but I think part of that is the realization that, or the reality that we're living in, that we are constantly learning new things from our experience, and honestly learning so many new things from you and your questions and the issues that you're facing as we've evolved over the months of this pandemic. So a lot of what's here have come directly from experiences that we have learned from other providers across the country. Next slide. Of the core activities that are outlined in this on the website, and in particular, the things I want to call out, one of them is the critical role of infection preventionists, the people in your centers that are trained and are dedicating their their work 24/7. And I know in many places there's multiple people that are focused right now on the infection prevention needs of the centers, but how COVID has shown us the incredibly important role that people with this training play in our facilities, and how we need to maintain a support for them even long after the pandemic has passed. A lot of things here are things that you are already doing and well aware of, and we'll talk through some of how people have implemented them as we go along. Next slide. So the other thing I want to call out briefly is the bottom bullet, implementation of a respiratory protection program. So, you know, when we talk about N95 respirators, and I know that these have been like gold at times because they're just so hard to access, and the supply has been challenged. And I think even though now I think maybe it's a little better, we certainly are worried about the fall and the winter and what respiratory viral season is going to bring. So we're all planning and probably stocking up. But something that really is a lesson learned, and something that we as an industry need to be thinking about, is the role of respiratory protection programs, fit testing, and the medical evaluation that goes along with making sure that our staff are able to use these pieces of equipment safely. And something that we don't focus on, but I think is just as important as the fit testing aspect of these programs, is the medical clearance that ensures that people are evaluated and know if it's safe for them to use these devices. You know, they're extremely tight fitting, and we have colleagues with respiratory illnesses, you know, that may not tolerate these respirators, these masks, for prolonged periods of time. And so I don't want us to forget that that is another big piece of why we need to be to be prepared for the future. So the topic was about infection prevention, control assessments, and readiness. So what I'm going to do is work through a tool that my colleagues at CDC have created, and then use some examples from the providers that I've visited over the years, not years, sorry, over the months of the pandemic. Next slide. You know, I guess in COVID time, it does kind of feel like years, but all of this stuff is happening so fast. So this is a snapshot of the tool. I'm really proud to also say that we now have posted a version of it in Spanish translation, which is you know, something that we should have done sooner, but I'm really glad that we have that option now, because even if it's used as a teaching tool for some of our partners and colleagues who maybe don't have English as their first language. This tool has been used by CDC staff, QIN-QIOs, and state and local health departments to provide on-site or remote support to nursing homes. We call it tele-ICAR, and you know, one of the things that CDC stood up very, very quickly in response to the needs of our provider community as well as our health departments was a team at CDC that was available to do remote outreach and calling to nursing home providers to sort of talk about prevention in a moment where the health departments might be working a lot with the homes that are dealing with outbreaks already. And so over the course of the last really 3 months, for maybe 3.5 months, this team has conducted just over 750 assessments across 22 different jurisdictions, state and local and tribal. Next slide. The tool is organized in basically 6 kind of sections, and we'll walk through the sections, but I don't think any of you are surprised or unfamiliar with any of this. So again, these are things that you are already doing most of the time, and then the question is, you know, are there ways that I can do it better, or there are other things that others have done. Is about visitor restriction and non-essential personnel restrictions, and is part of the strategic plan of keeping COVID out. And like I said, most facilities have been doing this since mid-March, and we know that it is, really taking a toll now on our residents and their families. So as we think about putting these things into place, I know you've also been doing a lot to support and maintain communication between residents and families. I've seen some really cool ways that people have created visitation options, and now, as some of you may be thinking about reopening and loosening these restrictions, how do we do it safely? Next slide. So here are my first set of illustrative pictures, all from providers all over the place. These are just examples of what I thought were cool ways that people communicated. So very clear on the far left that this is a center where we are not accepting visitors. And, it seems a little, back early on, I think it was super important that we were very clear about these things, because it took time for everybody to come to accept this new normal, and it is important to communicate frequently and clearly the things we were doing and why we were doing them. I saw this clean and dirty pens option I've seen a lot of people put a pump of alcohol-based hand rub at the table, as well as another strategy to make sure that people only approach the pens with clean hands. I had to check a box that I cleaned my hands before I touched
Dr. Stone.
anything. So these are really good things to keep incorporating into practice.
The last thing I want to say about this, these pictures, though, are that on the table, this was at the entrance where all of the staff were coming in to start shift, and so the center was putting all the updates, little reminders, educational materials, any things that changed in terms of policies, that information as they started their day. And the other thing I wanted to show you, phone, we connected on either side of that sliding glass door, and they can go, they were talking on the phone, they had keys to their workers. And, a few things that education, making sure that, again, the guidance is changing very rapidly, and even now, like the PPE circumstances that you're in are a different place, right? So things that they might have been doing back in April, maybe now they're not doing anymore because you've got enough supply. And so instead of extended use, you can do single use for isolation gowns, as an example. So I think having these places where staff can go and refresh themselves and get new information and reminders is really important. Everybody's doing a really good job of consistently checking not just visitors, but the staff every day. Some centers have gone to checking not just at start of shift, but mid-shift. Others have done start of shift and at the end of shift, so they're recording temperatures twice for the staff as they're coming in and out. And then, when we talk about staff, competency and reinforcing best practice and helping them learn, I think visual cues and all kinds of, places posting the information right at the moment in time when they need it is so important and so smart. So I have this picture in the center of the slide. I hope you can see it. The center had basically created a one-directional flow. You can see the red arrow. That's at the end of the circuit. But it was to help them doff. This was their doffing area, and they had the whole thing set up so that you got each piece off, and you had a place to dispose of. You had hand hygiene available immediately, and it was a visual and really wonderfully laid out process. And I think, this is a kind of innovation that was so cool to see. Next slide. Section 3 is education and monitoring and screening and cohorting of residents. There's a lot in here. And I think one of the things about the guidance, and there again, is that we know it's going to keep changing, that in addition to the regular updates and reinforcements to your staff, it's also important for families and residents to kind of know what's going on and how things are changing and the status. And I think the other piece that's coming up a lot right now are how to set up spaces to care for residents with COVID, and also it's going hand in hand with how to plan for testing, which I know is a really hot issue. Next slide. I want to just point out these resources for you. Hopefully you're familiar with them, but there's a lot of guidance on our website about testing, and we've actually split testing guidelines for nursing homes that are focused on the resident testing, and then a separate section on healthcare personnel testing. And so I want you to have both of those links, and I do think, you know, these things change frequently. The last update you can see was July 17th. Well, that was not that long ago. But as often, as much as we can, we try to push out to our partners when these things are updated. And what's nice about working with our colleagues in the QIN-QIOs is that they can also push that data to you and that information out to you. Next slide. And then we also have a really nice page that kind of walks through all the considerations that are around cohorting and management of new COVID cases, and gets into some of the things around designating a COVID care unit, how to manage new admissions, and kind of what are the steps that you need to take as you identify new cases or exposures among residents or your healthcare team. Next slide. A lot of interesting and cool ways that people were designating spaces, and you know, some of them were fairly high tech, where people were literally building walls to section off part of their building and keep it that physically separate. Other times we were, you know, using what we could get our hands on, you know, the plastic sheets, curtains, the various ways. Even just on the far right, you see just a kind of one of those straps that they have at the airport, you know, to like let us all be in line, or at an amusement park. Like, it's putting a physical barrier to help visually represent that this is a different space. We have different expectations of who is in here and what they're doing and what they're wearing, and all of that helps to sort of keep everybody, you know, very mindful of where they are. And at the top, I don't know if you can see it, but there's this room number, and below it is a piece of tape with a date. And this was from one of the center's quarantine units. So, you know, people were admitted, and then they would be in observation and quarantine for 14 days. So they put on the, just above the name of the resident, they would put a date so that they would know, everybody would know, here's when that person will be through their 14 days, which I just thought was really cool, because, you know, sometimes it's hard to keep track of that, and it's just right there at their hands. Next slide. And then a few more examples of ways that supplies and things are put available to staff. And I'm realizing as I'm looking at this picture that I probably meant to cut this slide. So let's go to the next one. You just have extra pictures in there. Okay, so sections 4 and 5, like, is the real meat of this work, you know, infection prevention and control supplies, which, you know, I think about not just whether I have the supplies, but where do I have them? How do I make supplies well integrated into the workflow of my healthcare staff? How do I make sure that at the bedside, people have exactly what they need at their fingertips, like access to hand hygiene? Because you know that while we're delivering care, even just with one person, there's often many opportunities to change gloves and perform hand hygiene before moving to another task. And the more accessible we make it, the better people are at, you know, successfully performing the practice. So I combine these two together because I think they're very interrelated. Next slide. So here is a series of images to show you how people made their PPE and other infection prevention control supplies accessible. So a few things to just point out. One is that centers got really creative about how they could, use space to help their staff store equipment if they needed to be reusing it or extending the, really this is reuse, right? Because we are not just extending it during a shift, but really we are using it for multiple shifts. And I just thought it was cool how they figured out how to hang and clip everything. And then there are others that were using shelves and plastic tubs and just ways to keep things organized, ways to make it clear whose stuff was whose. And I think that was really, helpful for just taking some of the thinking out of, your frontline's head, right? I don't have to worry about, did I bring all my equipment to work? I know it's there for me. I left it there. It's deconned appropriately, and I know it'll be ready and waiting for my next shift. And I think that's really important. The few places that I saw that were trying to have their staff responsible for things like their N95 respirators or their face masks, I think it was just hard, and you don't like PPE going in and out of your building anyway. So a couple of cool ideas for how to make that happen. And then a lot of images here clustered together. I'm sorry, it's sort of crowded, but just different ways, right, that people made PPE accessible. Like you see the hanging door version, and there's the CDC signage. One of my favorites actually is in the far right corner, where people have stuffed the cleaning wipes in the right adjacent to the, in that little space where they usually keep the fire extinguisher, and they still have it there. It's not gone anywhere. But how smart, right? Because we know we don't always feel comfortable leaving those things just sort of sitting out on a table, but this is how people had it at their hands, right at their fingertips when they needed stuff. It was available. And the other thing I liked is in the sort of center panel where you see the vital signs machine, and it's got a wipes right in the basket. So I'm going from room to room with this piece of equipment, and I can wipe it down as I go. So really all good examples of how to keep the infrastructure around your supporting their best practice. Next section is on communication, and that covers, everything from reporting to public health programs, and now, often people talk about NHSN reporting and try to see if there's needs or concerns there. It's also about how you are communicating with your residents, families, and staff, if there are new cases. And then another piece that I think we don't spend enough time talking about, but it's so important, is how we are coordinating with our community healthcare partners, like the emergency medical services, the transports, the local acute care facilities in the community. How do we work together as a unit so that we have a process and a good relationship, and we know how to, that when we need each other, we have a way to work it effectively, safely, and in a coordinated way. Next slide. The issue of notifications and a little bit of, I guess, more granular advice came out of one of the many guidance documents that have come from CDC and CMS, kind of reinforcing things that many of you were already doing, but I think it is a good reminder, even beyond COVID, that we have this process now for communicating when things are happening in real time to our residents, our staff, our family members. And so any outbreak, if it's norovirus or influenza, I mean, this is something that we should have as part of our ongoing communication strategy. Next slide. And just a shout out to my colleagues in the surveillance group at CDC who have been working to help as much as they can to make the COVID-19 reporting into NHSN accessible and meaningfully useful to you. And I know that it's not easy. None of this has been easy, and getting into this system took time, and it was probably the source of quite a bit of frustration. It may still be. But we'll have a session on that, and hopefully some of my colleagues from that group can come and talk about, some of the common errors and ways to avoid those, and ways to double check and make sure your data are accurate. because that's so important for all of us to be able to provide the right information and act on it quickly. Next slide. I just wanted to share additional resources that you can pull off of our nursing home infection prevention, COVID prevention website. They're down toward the bottom. There's short training videos. They're designed to be quick, 5 to 7 minute videos for frontline staff that just distill down some of the core infection prevention practices and why are we doing it and why is this important to you and to your residents. And, you know, I think sometimes we omit the why when we are asking people to change their practice or do this differently or remind them and in-service them on hand hygiene over and over again. But you know, the more we can connect how this is protecting everybody, how it's protecting their family and their community and themselves and each other, I think it makes it so much more meaningful. And then lots of different, you know, resources, hopefully that'll help with communication and just trying to get you started. If you were looking for what kind of language, how do I express what's going on about an outbreak in a letter or some kind of email posting. So resources there if you need them. Next slide. So that is really kind of all I wanted to say, and wanted to leave ample time for people to share their thoughts and their questions. And really, again, I apologize for the technical stuff. That's always a nightmare when it happens in the middle of a presentation. So thank you for your patience. But I also want to just say another heartfelt thank you to all the providers whose amazing work was illustrating all of these points for me. And really the advice was not coming from the CDC. The advice was coming from the provider community. And we continue to learn with you and continue to gain insights and information about how we can support you better through these discussions. So thank you very much. Lisa, I'll turn it back to you.
Thank you, Dr. Stone. We appreciate your presentation. Next slide, please. Please remember, we will get to all the comments and questions that we have time to address during the live event, but we'll attend to those unanswered post-event. I would like to take this opportunity to ask that you please complete the post-event assessment. We value your feedback on how we can improve these and future trainings. The link will be added to the chat box for your submissions, or it will automatically pop up at the end of the webinar. Before we go into the questions submitted, there's been a lot of comments and questions about the press release that I think went out today, announcing that CMS, in partnership with the CDC, is rolling out an online, self-paced, on-demand nursing home COVID-19 training focused on infection control and best practices. And that is the case. This is the second in the series. So thank you for joining us. The rest will be every Thursday going forward, except for the week of Thanksgiving and Christmas and New Year's holidays. So we will have these live. After they are completed live, we will put them on the QIO.org website for people to take, either again or if they missed one of the live sessions. The press release also mentioned that there will be a scenario-based learning module. That will be offered, we hope, by the end of August. We're in production of that right now. So stay tuned, and we will have more information for you as we get everything done. But lots of questions on that, so we wanted to make sure that we gave you an answer. So Angel, let me turn it over to you.
Thank you, Lisa. And our first question is, our facility only has one size N95 mask, which you cannot be fit tested for. Is this acceptable? We do place surgical masks over the N95 mask to ensure a tight fit.
Yeah, so thanks for that question. And I should say also that some of my other colleagues from CDC are on the line with us. Dr. Kara Jacobs-Sluska, that you've all met before, and you will be hearing from her, I'm sure, in the future on some of the sessions in this curriculum. as well as Dr. Elizabeth Soda and Dr. Abimbola Ogundimu, who are two members of the team that is supporting the ongoing tele-ICAR work for nursing homes and other healthcare facilities. So as this Q&A goes, I may defer to them if there are questions about the process or how to get involved in or to participate in a tele-ICAR. But as far as this question about so one size of N95 respirators, that worries me, of course, because we all don't have the same size face. And as somebody with kind of a tiny face, I know that if the only option for me were those larger regular size masks, regular size respirators, it would not protect me. And so I need the small. And really fit testing is, sometimes it's not just one specific style of respirator that you have to have, because there are some people who one type of respirator doesn't fit, but a different one does, and it gets very complicated. And I don't want to belabor that, except to say that we're all. It troubles me that you can't get access to more than one size. I recognize you're doing what you can given the supplies you have on hand, and so yes, this is what we call crisis standards of care and crisis strategies for PPE use when we don't have adequate supply of what we need. But I think one caution would be that for people where those respirators really do not fit well, you may want to think about not having them on the COVID units, and be thoughtful and selective about where you have them delivering care, only as just an added safety measure if you can. Thanks.
Thanks, Dr. Stone. And just a reminder for everyone, if you have any questions to ask, please go to the bottom of your screen, click on the Q&A box, and type in your question so we can read it out for you. I'll go ahead with the next one. A lot of controversy about testing staff in nursing homes still exists. CDC recommends weekly. States are resisting, and some are only allowed molecular and not antigen testing. Current molecular testing is taking 8 days for results. What is your recommendation?
Wow, there's a lot packed into that question, and an important reality check for me and our policy-making colleagues as well, because there is what is ideal when it comes to testing and the use of testing as part of our prevention strategies, and then there's what is the reality. So let me start with acknowledging if you cannot get testing results in basically 24 to 48 hours, it becomes exceedingly difficult to act meaningfully on those results. And certainly if it's taking 8 days, then it makes no sense to be asking your staff to go through weekly testing, because you haven't even told them the results from last week before you're trying to swab them again. So we have heard this. We know that it's a frustration. And so I would urge you to work with your state and local health departments. Ultimately, those are the individuals, these officials at the local jurisdiction level and the state level, they know the circumstance in the community better than anyone. And so we do absolutely rely on and defer to their guidance when it comes to implementation of some of these strategies. And I think that at least right now there is language that does talk about the role of the community incidence and prevalence in terms of risk and how that might inform testing. So states and local health officials, they need to be a part of the conversation. And then the last piece about the type of testing platforms, I will be honest, I am just still learning about the antigen platforms, the point of care that are being talked about and hopefully deployed to centers everywhere across the country. I know that there are some vulnerabilities to point of care devices, and there's a concern about the reliability of its detection of virus, these are platforms that we're still learning about, and we're learning as we implement them more, we'll have better information about how to use them effectively. But there are going to be more guidance coming out from CDC about how to utilize these different modalities of testing for virus, like our colleague was asking. There's platforms that amplify the RNA of the virus. There's platforms that are looking at the protein antigens on the outside of the virus, and they're detecting virus, both of them, but they're doing it in slightly different ways. So we will continue to inform and provide the best guidance we can as we learn how these tests perform and how we can best, most efficiently use them. Thanks.
Thank you, Dr. Stone. Our next question is, can you discuss the benefits of telemedicine that telemedicine offers when caring for residents in isolation, especially for outside specialists and for training and education?
Yeah, one of the really innovative strategies that was recognized very early on as super important to incorporate into care in nursing homes was the idea of telehealth and remote visits mediated through iPads and things like that. And a lot of it, is to reduce the traffic in the building. It's to reduce the number of people that have to come in and out. And so there is a benefit to, in terms of safety and reducing the potential for COVID introduction. But it has to be balanced with the, potential downside of trying to do an exam from your living room, right? I mean, there are some things that lend themselves quite well to telehealth assessments and interactions, and others that may not. And that is an important discussion with medical director and clinical consultants to sort of determine, okay, what is our threshold? What is our approach to this? And I'll give you one example that I heard from a center months ago, which I thought was really, really smart. Like, they had a regular wound care consultant that would come once a week, a physician who, would assess and outline the dressing, strategy and treatment strategy for the wounds of the residents who needed them. And what the center proposed to do was to use telehealth for the evaluation and care of residents where they felt like things were going well, the wound was making progress, healing was well, there was no concerns. But in circumstance when they were really worried that there was a problem, maybe the wound healing was stagnating, or maybe it was something was breaking down, and they really needed hands-on, a better, closer evaluation of the circumstance, then the physician would come. So it wasn't an all or none. It was based on, like, what's the level of need, what are the evaluation goals, and how can we best utilize this as part of, but maybe not wholesale, all of the way we deliver care. Thanks.
Thanks, Dr. Stone. The next question is, can you clarify what the definition of suspected is? Is there a specific criteria?
So I'm going to make the assumption that this is around NHSN reporting, because I know that this is a question that has come up before. And again, I'm really glad that there's going to be a session dedicated to this. So come back and listen to my colleagues and others who are more familiar with all the tips and tricks. But basically, when it comes to NHSN reporting and what would be a circumstance where I would consider somebody a suspected case, and what are the circumstances where I would not? So it's based on clinical suspicion, signs and symptoms that make you very concerned about COVID, and plus minus, a test that may be ordered, may be pending, there's an intent. And sometimes tests just cannot be accessed. And so I'm going to treat this resident as if they have COVID-19 infection. I'm going to not, the way I approach the care and what I'm offering and all of the PPE, et cetera, that's being used in their care is as if they have COVID-19. That is an example of suspected COVID that should be reported into the system. On the other hand, if I am doing weekly testing of all of my residents or every, pick an interval testing of all my residents as part of a reopening strategy or part of a state initiative, then I'm not going to, even though I have all these people with tests pending, right? The entire unit or a subset of the unit have tests pending, but I'm doing it not because I think they have COVID, but it's part of my strategy for surveillance. Those do not get counted as suspect cases. So the real distinguishing factor here is your clinical concern and clinical signs and symptoms and the way you're managing the resident. And and that's what differentiates suspect COVID cases from people who are, have a test pending, but they're asymptomatic. Hopefully that's clear. Thanks.
Thank you, Dr. Stone. The next question is, can we reuse the brown paper bags from day to day for masks?
Yeah, I'm laughing a little because I think this is crazy that we're in this circumstance, right? That we have to be worried about, using brown paper bags to store masks at all, let alone. Now, I'm hoping you're all, when you refer to masks, you're talking about respirators. I want to differentiate them from procedure masks or the surgical face masks because I don't really love the idea of trying to salvage and reuse those pieces of equipment day after day. So that's just a little personal aside. But in terms of respirators and the way we store them, I don't know. That's the honest answer. I don't know if there's a level of risk if you use the same bag for, a couple of days while somebody's storing their respirator there. I mean, you could, we hope, right, that between our careful practice, and using face protection, if we have face shields, for example, that the respirators themselves are not as exposed. And some people do add a layer of a surgical mask over respirators, which I'm sort of not sure about. Like, I understand it because you're trying to just protect that piece of equipment and it's very precious. I also worry a little bit that it's just, those are already very hard to breathe in, and now we're adding another layer, and it just, what's the level of comfort for my staff? So I guess that's a balancing act that we all have to kind of adjust and determine on our, based on our supply and what our feedback is from our frontline staff. They're the ones that you need to be asking that question to. But I don't ever want you to start handling your respirator or anything without cleaning your hands first. I never want you to come up to your face without performing hand hygiene first, because we need to know we have clean hands. And so if we have clean hands and we're careful about how we remove the respirator and handle the bag, then I don't have as big a concern that the whole outside of the bag, for example, is contaminated. But I think it's all about technique. And I think a lot of centers have decided that when they change out the masks, that's when they, get fresh paper bags, I guess. And so I guess that's where I'll sort of leave it to your good judgment. Thanks.
Thank you, Dr. Stone. The next question is, can you provide any more information regarding the term airborne transmission and how to take that into account when trying to set up a designated COVID unit in a nursing home? For dementia residents, we are unable to close room doors for safety reasons, and most nursing homes don't have enough space to create all the recommended designated units, i.e. a unit for long-term care, one for new admissions, observations, suspected, and confirmed.
Thank you for that question, and thank you for sort of sharing just the real struggles and challenges that so many of you are facing. I know there's a tremendous amount of discussion right now about how does this virus transmit. And largely, when we talk about respiratory viruses, we talk about droplet precautions, which incorporates face masks to cover the nose and the mouth. Those are the vulnerable mucous membranes that droplets can land on and infect somebody, and then eye protection to cover those mucous membranes. And frankly, we did not do as much of a good job anywhere in healthcare covering eyes and thinking about eye protection when it came to respiratory virus transmission until more recently. And it is becoming a standard and something going forward in time that will absolutely be incorporated into care. So when we talk about airborne transmission, generally, the bug that I use as my poster child, there's kind of two. There's measles virus, but the one that I talk about more because I like it so much is tuberculosis, right? Tuberculosis is mycobacteria, and when it causes active infection in the lungs and people cough, they can cough out very, very tiny particles containing the bacteria. And the relevance of that, as opposed to respiratory droplets, has to do with the weight and the distance that these different size and weighted particles can go. So TB is small enough, light enough that it literally can float in the air currents, and it can stay in the air even after I've left the room. Somebody who's susceptible and not wearing protection, walking in immediately, or even, sometime after I've left the room, if the room is not handled with the right environmental controls, they can get infected because this is an organism that it's floating in the air and you inhale it right into the lungs. That's how we become infected with tuberculosis. I don't think that is what we are envisioning when we talk about is COVID, is the SARS-CoV-2 virus airborne. Or what we're really thinking about are not just the heavy respiratory droplets that maybe come out when somebody sneezes, coughs really, hacking and wet cough. Okay, so those probably are heavy droplets that go, 6 feet or so and drop, and they drop. And so they're not containing virus particles that are suspended in the air. However, I think what we're exploring and understanding more about is there are microaerosols, smaller droplets that probably do travel more efficiently and not super far, like it's floating in the air for a long time after somebody's gone. But if we're close to one another, and this is where social distancing becomes really important, because, and I recognize that in nursing homes, the resident care activities you're doing put you face to face with the residents. So one of my suggestions, and something I feel like we need to talk more about, is asking residents who can tolerate it to put masks on themselves when providers are coming in to deliver care. Because if I'm wearing a face mask for source control, that's one layer of protection for both of us. But if both of us are wearing masks, that is doubly protective, and it really reduces the potential for any cross-contamination or transmission. So when residents, and they should all have their cloth face coverings, right, because we're asking them to wear them when they go outside of their rooms. When somebody's coming to deliver care, let's say help transfer somebody from the bed to a chair, or maybe help them, assist them to get to the bathroom and back, have the resident put a face mask on too, so that there's an extra layer protection for both people. And the microaerosol and the aerosol generating procedures, I know there's a lot of discussion about that, and I do think that we're learning that there's probably some circumstances where the viral particles are in a smaller medium that can be inhaled, and so that's why we're recommending N95 respirators as much, as if they're available to our teams, because we think that is important protection as this continues to become, as we continue to learn about this virus.
Thank you, Dr. Stone. The next question is, for new admissions, is the guidance now 10 days instead of 14 days for observation and quarantine?
Yeah. Thank you so much for asking that question. I think this is really important. So the answer is no. It is not 10 days. It is still 14 days. So let's talk about the difference between recovery from COVID and COVID exposure and observation, self-quarantine or quarantine, okay? So there's two very different things happening. So I think the person asking the question is familiar with the discontinuation of transmission-based precautions guidance, which does say that individual can be removed from precautions as they're recovering from their COVID infection, as long as they've been in precautions for at least 10 days from the onset of their illness, or if somebody's asymptomatic from the onset of their positive test, and have had at least 24 hours of clinical resolution of their fever without antipyretics, so without taking fever-reducing medicines, as well as improvement in their other symptoms. So the 10 days there is based on the fact that we've seen more and more data showing that, especially with people who have fairly mild to moderate illness, the shedding of transmissible contagious virus drops substantially, and it becomes very hard beyond 10 days to culture virus, not detect. You can detect the virus using the PCR for longer than 10 days, and that's happened quite a lot. I'm sure you've seen it in your own experience, but to get culturable, transmissible, what we call replication competent, which means the virus grows and it can replicate itself, that does not happen for most people beyond 10 days. So, and it happens, it ends at 9 days often, or sooner. That's recovery from COVID infection. Now, COVID exposure, when you're exposed to this virus, it can incubate and not start to manifest symptoms up to 14 days from your exposure. That is not changing. That is consistent and will stay that way. So we recommend the 14-day observation and quarantine for new admissions and people who you're worried about had an exposure, because you want to observe them for the duration of that window that they may be potentially incubating and eventually could become symptomatic or just become, infected and shedding virus. So that is an important distinction between the time to recovery versus the incubation of the virus, and that's why we were not going to change that 14-day duration. Thanks. It's a really important question.
Thanks, Dr. Stone. We're coming to the end, but let's try to get in one more question. American Heart Association stated that during the resuscitation, viral particles can remain suspended in the air with a half-life of approximately 1 hour and be inhaled by those nearby. In the absence of a well-fitted N95, would you recommend the staff to do manual ventilation in addition to chest compression until EMTs arrive on the scene, who will perform the intubation?
Yeah, thank you for this question. I will admit that I do not know that I can give you a solid answer to that question, and I'm afraid to try to give advice that I don't feel prepared to, justify or back up. This is a very challenging area. A lot of concern and discussion around resuscitation and safe approaches to doing that. I wish I could answer your question with some specifics about how to approach this, but I will say that the most important point to remember for your team is make sure you're protected even in these really urgent and emergent circumstances where everybody's rushing to try to help, you've got to make sure that you've got the right equipment on to be safe. And so having a N95 respirator and eye protection and the gown and gloves to, and I think that's a very hard thing for us to do as clinicians, as physicians and nurses. Our immediate response is to just jump into the fray, and you see that all the time in emergency rooms, right? They just jump into the fray, and who cares if there's blood and all kinds of stuff happening? We need to be there helping that patient, and I get that. But I remember talking a lot about this when we were talking about Ebola several years ago, and in particular advising first responders to recognize that they have to be safe first, because this is a situation where jumping into the fray without being protected can do more harm than good.
All right. Thank you so much, Dr. Stone. We appreciate all your time today, this wonderful presentation, and you taking the time to answer all the questions. Next slide, please. Everyone, please join us for the next call in the series, which is next Thursday, July 30th, from 4 to 5 p.m. Eastern Time. The topic is going to be on COVID-19 knowledge for the frontline staff, and will feature Alice Bonner from the Institute for Healthcare Improvement and Lisa Porter from the National Association of Healthcare Assistants. Registration is required, and they'll put it in the chat so you can use that registration link now. Alternately, you can register for the event or the entire series on the QIO program website, which is qioprogram.org/nursing-home-trainings. Next slide, please. Thanks again for your participation in today's call. We hope you found some value in the topics discussed. Again, please take a moment to complete the survey from today's event. We do value your input, and it will pop up automatically as we conclude this presentation. So thank you again, and have a very good day.
That concludes today's webinar. We will now disconnect. Thank you.